Hi, my name is Justin St-Maurices and I'm here to present my thesis today. The name of my thesis is Determining Non-Urgent Emergency Room Use Factors from Primary Care Data and Natural Language Processing, a Proof of Concept. What I'm going to do today for my presentation is talk about the study's rationale, go through a literature review, talk about why this approach has not been used in the past and why this is a little bit unique, rather very unique. I'm going to go through some methods and results, talk about, do some discussion about those results, talk about the limitations, and wrap up with some conclusions. Essentially, the rationale for this study was the fact that I work in primary care. I know how much investment has been put into primary care data and primary care computerization, and I wanted to see ways that we could take advantage of those investments that we've made. I've looked at a lot of research and tried to figure out who's been talking about that and who's been looking into it, and there's a lot of work out there about primary care data. The work of Majid is a good example of a work that kind of summarizes the variety of purposes that we could have if we had a fully digitized, fully available primary care data source. The obvious main reasons to have primary care data are to provide healthcare, and the immediate business cases are for avoiding the duplication of tests by making sure that tests that are done in primary care aren't duplicated in the urgent care setting. There are a lot of secondary uses as well, again as discussed by Majid, and those include purposes of public health, epidemiology, auditing the effectiveness of care, doing some genetics, looking for data for general research, basically taking information that we have in primary care and starting to linking that to other sources to see if there's relationships between what we have in primary care and what we have in those other databases. Primary care data is interesting because it's biopsychosocial data, it's not acute, and it's very longitudinal. So we might have data in there from someone's birth all the way to their death. In theory, we would have access to their full psychological profile, their family history, their friends. We'd know about the crises that they've gone through, their successes, where they work, what they've tried, the drugs they've had. Biopsychosocial data is really a fully inclusive set of information about a patient that normally would be very hard to gather if it wasn't fully stored in a primary care source. So, the rationale for my study was to look at this investment we've made in Ontario and see how we might put primary care data into action. I wanted to prove that primary care data could be used for secondary purposes. We've made these investments, now let's start taking this investment and doing something cool with it. So the research question that I ended up exploring was looking for biopsychosocial factors that were associated with greater non-urgent emergency room use when extracted through the analysis of primary care data with natural language processing. So in essence what I did is I created biopsychosocial profiles for patient records by extracting certain keywords and certain sentences and themes, and then I took those themes, they were coded, and I associated those specific codes with non-urgent emergency room use to see if there were certain codes that were better predictors than others. And that was done by taking the primary care data and doing some natural language processing. So in the past there has been a variety of literature that has investigated inappropriate use of emergency room services. As I went through, I did come up with several thousand articles, but a lot of those studies were about cohorts, so they were about the homeless, they were about the elderly, about children, mental health patients, those kinds of things. A lot of those studies were obvious by looking at their title on abstract that they weren't really appropriate for what I wanted to do. I also rejected some other studies based on the fact that they didn't have details about specific predictors, they didn't report a definition of what they had considered inappropriate or appropriate, or they didn't have specific odds ratios numbers reported as statistics in their publications. At the end of the day, I ended up with 23 articles that did meet the selection criteria. The findings, which I do detail in fair depth in my thesis, in summary though, and if you don't want to read those 5 pages, is that there are different definitions of inappropriate use. There are several studies though that used CTAS, which is a Canadian Triage Acuity Scale, and that was used, or something very similar to it, in several studies to categorize inappropriate use. I ended up using that same triage system as a proxy measure for determining if someone was using the hospital appropriately or not. In essence, what a CTAS scale is that it ranks a patient from 1 to 5 for each emergency room visit, where 1 is something that a patient clearly has need for being there. They probably need resuscitation. It is a dire mortal emergency. And 5 is the other extreme at the emergency room, where someone might have a hurt tooth or might have something that might not be very appropriate for the emergency room, and it's not really urgent, and they are typically triaged much lower, and they are seen on a much lower priority basis. Another finding that was discovered by looking through all the articles was that a lot of people and a lot of existing studies use questionnaires and surveys. They were very qualitative in nature, and they had codes and categories that they wanted to investigate before they started looking at data and interviewing patients. That's in a little bit of a contrast to what I've done, where I took the entire series of data and found out what were the common biopsychosocial components, and then I built the relationships that I found between that and inappropriate use. Another thing that was different than my study was the fact that none of the existing studies that I found had used primary care data to investigate the question. So the question is, why has this approach not been used in the past? One reason for that is that getting access to primary care data can be difficult because of privacy and political reasons. Same thing goes with getting hospital data, but at the same time accessing and linking that data to primary care records is also a challenge, because that has to be done under the constraints of privacy and getting access and going through a lot of bureaucratic loopholes. And even if you had access to primary care data and access to hospital data and could link it, you'd still need a fair bit of research expertise and technology that's often not available to analyze that data and go through it all. So essentially, we have a very small, uncommon intersection of themes here that I was lucky enough to fit in the middle and have access to primary care data, to the hospital data, and to the technology and expertise to do this type of analysis. It is a very uncommon intersection, and very likely the reason that this approach hasn't been used more in the past. In terms of the methodology, the first thing to realize is that this was a proof of concept. The goal was to really show that we could take data from the primary care source, analyze it, code it, and then interpret it all in one flow. So the goal was to really show that that was possible and that we could get some meaningful results out of that. So in terms of the type of data to use for the analysis, Wilcox et al. Suggested that only 12 or 15% of the physician population was using structured data in their medical record properly. And in contrast, 85% of them were using free text fields by way of dictation or just typing away, and that information was much more available. So in terms of choosing whether or not to rely on free text data or coded data, one of the drawbacks of trying to use structured data is that it's not consistent, or sometimes it's not used, and the use of free text is much more common. In addition, the goal was to extract biopsychosocial dimensions, and they were going to those kind of nuances of someone's social characteristics, housing status, mental health state, and some of the physiological symptoms. Those types of words and narratives were going to be much more rich in free text, and it better represents the physician's stream of consciousness. So because of those reasons, I wanted to focus in on free text data instead of coded data. Now, in order to use free text data, I had to go down the path of natural language processing, which I'll explain in a bit. In terms of data sources, the data was taken from 8 physicians that were of different age, sex, and from different educational backgrounds, and that was intended to give a statistically diverse sample also based on the availability of data. The idea was to prevent doctors with similar backgrounds from using the same terminology to describe the same things. So the data sample should have different types of free text describing different things from people with different backgrounds. The data from the primary care free text was cross-referenced with hospital records anonymously by using health card number hashes. At the end of the day, there was 13,878 patient records that were linked to 7,466 emergency room visits, and those emergency room visits were taken over a 3-year period. After removing health card numbers that were null or invalid or that didn't exist in the primary care data set, we lost about 500 visits from the ER between that period. So the design that took place is, as I mentioned, we had primary care EMR data, which you'll see in the top left of the screen. That was exported and de-identified in Ontario MD's CDS 3.0 format. And then that data was fed into the Data Analyzer Toolkit. Now that Data Analyzer Toolkit is a piece of software that I wrote, and that took advantage of some APIs that were available for MetaMap and for Gate. So the Data Analyzer Toolkit effectively took the free text data from the raw data source and spit that out to Gate and to MetaMap, and those were the natural language processing engines that would associate concepts and scores and return that back to the piece of software that was created. Gate is a tool that was designed at City University in London, and MetaMap is a tool that is designed and supported by the National Library of Medicine in the United States. So that core natural language processing tool is something that I used and I didn't create myself, but I took advantage of APIs and was able to incorporate those technologies into the Data Analyzer Toolkit that I used. So once that natural language processing analysis took place and those biopsychosocial codes were scoped out and found, then that data was written to a MySQL database that included the primary key, which in this case was the health card number hash, and the results of that annotation. Once in MySQL, I was able to write queries and stored procedures that created the kind of meshed the data in a way that was appropriate to be put into a regression model. So that was exported to a CSV file, and then I used R, which is an open source statistical package, and I performed logistic regression to figure out what the relationships were between inappropriate use and specific biopsychosocial codes. So what that looked like in terms of the actual analysis, this sample table here is what was able to create what I was able to create with MySQL and stored procedures, and what was basically the output of that was the patient numbers as well as their age, sex, gender, and whether or not they had a inappropriate use in the last 3 years. And then the final element of that was whether or not the biopsychosocial code existed in that profile or not. So I ended up using 4,028 different biopsychosocial codes, and the reason for selecting 4,028 different codes is that I selected codes that were common, and I defined common by selecting codes that were present in at least 99% of the population that I was studying. So if the code was found in 99% of the primary care data set, then that code was used in this regression model. So once that table was created in MySQL, it was dumped to a CSV file and analyzed with R, and basically what occurred after that is that this model of inappropriate use and the code, that model was analyzed 4,000 times, and that's how I determined my results. So at the end of the day, for those 13,000 some records, there was 10,823,636 codes that were extracted. And to give you an idea for what those codes looked like, you have here some frequency histograms that give you a feel for the number of table annotations that existed in each chart, and below you get a feel for the total of unique annotations that existed in each chart as well. So on average there was about 400, 500 or so different biopsychosocial codes or other codes that existed inside the record for each patient chart. In the top right, you'll also see the breakdown of the CTAS levels that occurred at the general hospital. The most common was 3, as you can see, but 4 and 5 were what were considered inappropriate. So the biopsychosocial codes that came out to be the most statistically significant are listed here. So these are the codes that were categorized as biopsychosocial by the Chief of Staff at the Guelph General Hospital. And this is also being limited by those types of codes that have a probability of 0.001 or smaller and an odds ratio that's greater than 2. Those two filters reduce the probability of results that might have been caused by random error, and they also make sure that we're only keeping results that are the best predictors. So this is essentially the answer to the research question: what biopsychosocial factors are associated with greater non-urgent emergency room use when extracted through the analysis of primary care data with natural language processing? And what's interesting here is that the themes of mental health and the themes of pain are dominant in inappropriate users by doing this analysis. And this is similar to other themes that have been explored in the literature. For example, there's a study by Pereira et al., Caird et al., Aflalo et al., and Martin et al. All of those studies kind of reiterate in some capacity these themes. And this is also anecdotally in line with what I've heard from the Chief of Staff at the Guelph General Hospital. So as far as a proof of concept goes, it does show that we can take the primary care data, do some natural language processing on it, and we've come up with reasons for inappropriate use that are well in line with existing literature and well in line with anecdotal evidence. Statistically, in this study, the use of odds ratio and logistic regression was basically all that was done. So it's a simple model, there's no multivariate considerations, though they probably exist. So while it would have been really great to do multivariate analysis, the univariate analysis significantly reduced the complexity, especially because we're talking about 4,028 dimensions. It would have been very, very difficult, and probably another research project in of itself, to do multivariate analysis on that many dimensions at the same time. So the implications are that these results are maybe not ready for application because of the very simple statistical model, but in terms of future work, there's definitely room for multivariate analysis, and what would be interesting to do would be to discover some constellations of terms. So maybe certain codes, certain biopsychosocial codes in combination are better predictors than codes that are used in isolation. In terms of natural language processing, as I mentioned earlier, GATE and MetaMap were used as the core natural language processing engines. And those were third-party tools that have been worked on by other institutions and working groups. The problem with those tools is that they weren't perfect, and there were errors that were introduced in the text interpretation. For example, there were some regionalisms. In this case, GGH and Bullfrog Mall were examples of regionalisms where the reference in the free text makes sense to someone who lives within that community, but it doesn't make sense for someone that lives outside the community, and therefore MetaMap didn't know what the physician was talking about in their free text note. GGH in this case stands for the Guelph General Hospital. That's not what the GGH gene, which is something quite rare and something that MetaMap decided that GGH meant. Bullfrog is a geographic reference in the city. Bullfrog Mall, Bullfrog Pharmacy, near the Bullfrog Pharmacy. There were some texts about where these patients were coming from, and that might be interesting in terms of a biopsychosocial profile. People who live near the Bullfrog Mall have a particular tendency to do things, but at the same time, treating that word bullfrog as bullfrog doesn't make sense. There was also some euphemisms that were problematic. Kicking is a great example. For example, kicking was used in a couple different ways. In one instance, it was written that the patient was kicked out of the mental health support group. In another, it said the patient was kicked in the face at the bar. In another, it said patient tried to leave a message, but the answering machine did not kick in. In another, pacemaker will kick in if the heart rate falls below 60. In each case, the natural language processing correctly converted the verb kicking from sentences, but the meaning and implication is very different in each case. The first instance is an important status indicator for a mental health treatment plan. The second would explain and qualify physical trauma. The third is really trivial and meaningless from a medical standpoint, and the fourth is an independent, important component of a complex medical treatment plan for someone's heart condition. The implications of these errors is that there were incorrect associations of concepts in the text. And future work is twofold. One is improved natural language processing with GIS integration. GIS is a geographic information system that would have the ability to deal with some of those regionalisms. It would be able to detect that GGH in the Guelph community means Guelph General Hospital, but GGH in London, UK probably doesn't mean Guelph General Hospital. Future work would also involve creating better standards for documentation so that we don't have euphemisms in there in the first place. Processing time was another important piece of the analysis. It's worth noting that it took 7 days of processing time to do this analysis. If we extrapolate that for 1 million records, which is a fraction of the size of the Ontario healthcare system, using this technique would be 540 days of processing. That means that this solution is not very scalable, and it's really not feasible for small clinics to conduct natural language processing in this way. Future work would be to create a better architecture, maybe using some cloud computing. There's been examples of using cloud computing in bioinformatics research that involve large quantities of data. This could break down the number of computations and do it at the same time instead of sequentially. This is similar to what the Search for Extra Intelligence does, where they take their radio data and they distribute it to computers throughout North America that process and analyze the data during the screensaver time. Another solution would be to do real-time processing. So instead of taking free text content and looking at it after the fact, if the data was processed in real time as a physician interacts with it and creates it, that would be out of the way and there would be no additional processing time required down the road to do the analysis and use the data for different purposes. There are some limitations to this study. The use of CTAS for categorization has been debated. CTAS 4 or 5 were considered inappropriate, but it's very likely that those 4 and 5s could be used for appropriate reasons. In Guelph, a suture removal is done at the emergency room, and that would be a CTAS 5, but that's kind of a community accepted reason for going to the emergency room. The categorization as inappropriate did not take the time of day into consideration or the referral source. So if a patient called Telehealth Ontario and they were told to go to the emergency room, they're still categorized as inappropriate. Or if it was 4 a.m. and they had nowhere else to go, that was still categorized as inappropriate. Natural language processing also didn't take negation into consideration. It analyzed annotation, themes, and codes. So in the text, if there was a discussion about cancer, it would take the theme of cancer and it would regress against that as a biopsychosocial code, but it wouldn't be able to determine if they said this isn't cancer but it might be this. It would still see the theme of cancer and would do the regression against that theme. So in conclusion, as a proof of concept, this study shows the merit of the methodology. The method shown takes the data from primary care. It uses natural language processing, extracts biopsychosocial codes, and then was able to use odds ratios to find a relationship between those codes and the inappropriate use of emergency rooms. And those results actually replicate what is currently existing in the literature. So that's a good thing. And what could be done with this is that this technique could be used to characterize other types of system use. Instead of looking at inappropriate emergency room users, you could look at appropriate emergency room users. You could also start cross-relating this data to mental health, to community access centers, to diabetes education, and start creating biopsychosocial profiles of different types of patients who are using different types of services. Once refined, and once getting out of the proof of concept phase and getting something that's more ironclad, this technique could be used to predict usage. It could support decision making. It could be used to allocate resources. It could do a lot of interesting things. So I think my goal of showing that primary care data can be used to do interesting things, can be used for characterizing the healthcare system. I think as a proof of concept, we're good, and we've demonstrated that. So I did want to take some time to thank my supervisor, Dr. Alex Kuo, We only had one committee member. It was Dr. Andre Kushnaruk, and I do appreciate his support as well. And externally, I was assisted by Dr. Nicola Shaw. She is a primary care data expertise type of person, and her help was muchly appreciated. Philip Gooch helped with the natural language processing and is actually the author of the plugin that links Gates to MetaMath. And finally, Dr. Scott McDonald was very helpful in doing the statistical analysis for the simple odds ratio univariate analysis. So I do appreciate all of those people's support and help throughout this project. Thank you.